Chapter 34, Pediatric Emergencies. As most of us know, it can be a challenge to take care of a pediatric patient. Pediatrics are different than adult patients, of course, but they differ more than just anatomically and physically. They also differ emotionally from our adult patients. The illnesses and injuries that they incur can be specific based on the age of the patient. It's important to remember that children are not just small adults. And unlike many of our adult patients, they fear us. They fear anybody who is not their parent. Once you learn how to approach a child and to take care of them, it makes things a little bit easier. This may be more challenging if you do not have children of your own, but if you do, then perhaps it might be easier to deal with young people. Communication is always the key, and of course, good communication with the family will help relieve the fear of the patient. If we have a calm parent, this usually results in a calm child. The parent is agitated or they're afraid or fearful because we're there, well, the child is going to react in a similar manner. So always remain calm, professional, and sensitive. Remember back to the chapter when we talked about the human body and the age process? Remember the different behaviors, the different age groups? Obviously, we have them divided into infancy, toddler, preschool age, school age, and adolescent. Infancy is defined as the first year of life, whereas 0 to 2 months, our patient spends most of their time sleeping and eating. They don't know the difference between parents and strangers, so they respond to just about everybody. And of course, crying is their main means of communication. From 2 to 6 months, persistent crying can indicate irritability or a lack of eye contact with the person who is a serious person in their life, perhaps their caregiver, their mom or dad. From 6 to 12 months, they may cry if separated from parents or caregivers. They might persistently cry if they're hurt or if they're hungry or if they're injured. As we do an assessment with an infant, we typically assess them from a distance. Usually mom or dad would hold the baby. They provide comfort for the child. We don't want to do any painful procedures at the end of the assessment, or excuse me. We want to make sure that we wait to do all of our painful procedures, such as perhaps checking their blood sugar or even blood pressure, for the end of our assessment. Always explain to the parents what we are going to do to their child. After infancy is the toddler years, roughly from 1 to about 3 years of age. During this time, our child experiences rapid growth. The toddler years are when your child is, well, fearless to say the least. They're explorers. They want to find out everything there is to know about the world around them. So they seem to have little or no fear. But because of this, injuries can increase. They're not able to fully chew their food yet, and they explore many things by sticking them in their mouth. This results in the increased risk of choking. Older toddlers between 18 months and 24 months may cling to their parents. This is where, or a comforting toy, this is where stranger danger becomes a thing. They might resist separation from the caregiver. It might be hard for them to describe the pain or to isolate it. They're just learning how to communicate. So unlike with our adult patients where we typically go head to toe, we want to go toe to feet with our pediatric patients. Preschool age from 3 to 6, again, they're still exploring the world with their mouth. So sometimes they can aspirate an object. They can understand directions. They're a little better at explaining painful areas, but still much of the history that we get is from the parents. Be simple and direct in our communication. Never lie to the patient. Never tell them that you're going to do something that doesn't hurt and we know that it's going to hurt, like checking their blood sugar, for example. Begin the assessment of the feet, moving to the head. Cover up the site of the wound or infection if we can, or injection site, excuse me. If you have children, you know that any little mark on them needs a Band-Aid. I remember when my daughter was little, every time she had anything on her skin, it had to be covered up with a Band-Aid. This is very much true with our preschool age patients. So don't be afraid to put a dressing over it. And they're also developing modesty at this time. So let's make sure that we keep them as covered as possible, just like we would with any other patient. As we move into the school age years, we see that the children begin to understand death, the concept of that. It's more than just an unknown what happens to somebody. And some of them may be afraid that they themselves are going to die because of their injuries. So we need to be comforting in that area also. Most of the time we can begin our assessment more like an adult. We try to gain the children's trust. We talk to the child. We explain to them what's happening. We can use their caregiver or their parent or their person to help us along with our assessment. And they've probably had a doctor's visit or two that now they kind of remember. So that gives us a little bit of an advantage when we're checking out and we're assessing our patients. So children like to feel like they're part of the decision-making process. So sometimes we have to give them choices. That doesn't mean that we give them choices where they get a way out of being evaluated. For example, we have to check their blood sugar for, we could ask them, do we want it on their right hand or their left hand? Allow the child to listen to his or her heartbeat. Always kind of a cool thing that we can do with our patient by putting the stethoscope in their ears and letting them see what's going on. The adolescent patient can be a little more challenging. Their bodies are grown, well, just about grown. Many of them are well developed, but emotionally, they may still be not as developed as a full-grown adult. Also during this time, remembering back to your adolescence, it's a time of experimentation and risk-taking. Perhaps they've engaged in some illicit activity, or they're doing things to kind of get a thrill, whatever it might be. They're often able to understand the complex concepts of our treatment and the options that are revolving around that. If possible, we always try to have a EMT of the same gender do the physical assessment. And one thing that is we need to keep in mind in our adolescent patients that it is possible for our female patients to be pregnant. So explain to our patients what we need to do and why we need to assess them and what we hope to accomplish as a result of this. So as we go through A&P, the body is growing and changing very rapidly. Children, literally, especially in the toddler years, can grow overnight. With this, can bring some physical changes to our patient. So we first have to understand some of the physical differences between our pediatric patient and our adult patient. And then we change our patient care accordingly. For example, in the respiratory system, we know that the pediatric airway is smaller. You can see by the illustration here, the tongue is proportionally much larger to the patient's airway as it is to the adult airway. You can see the airway itself is much smaller as it relates to the adult airway. The lungs are smaller. The heart is a little bit higher in the chest. The glottic openings are higher, positioned more anteriorly in the neck, and appears to almost be non-existent in some of these patients. As they develop, the neck gets proportionally shorter, or excuse me, proportionally longer as the vocal cords and epiglottis achieve their correct position that they will have as an adult. That's one of the reasons that in the voice can change as things move around and kind of stretch and such. Again, the anatomy of the airway differs from an adult. They have a larger, rounder occiput, which when they're lying on their back, then puts them into a hyperextended position, and thereby they can block off their airway. They got a large floppy epiglottis, and the diameter of the trachea of the infant is much smaller than it is for an adult. Children have a oxygen demand twice that of an adult, and their diaphragm, it helps, obviously with respiration. This is a big muscle there, but it dictates the amount of oxygen that's inspired when they're breathing. And it's some of the muscles, some of the abdominal stuff isn't quite developed a little bit. So sometimes you'll see little kids, what we refer to as belly breathing. That is different than if we saw that in an adult. For a pediatric patient, that may be their normal way of adjusting the respiratory rate. The breath sounds can be a little more easily heard because of thinner chest walls, but that also can create some confusion sometimes because of the thinner chest walls. Sometimes the breath sounds are more diffuse. It sounds like they're all over the place instead of just near the lungs. So it takes a lot of practice. It's important to remember what the normal pulse rates are for our pediatric patients. So rather than trying to memorize them, take a look at what the skin signs are telling us. Of course, we want to know those other numbers. So signs of vasoconstriction include pale skin, weak distal pulses in the extremities, delayed capillary refill, cool hands and feet. On this chart, we have what the newborn, or what the response, excuse me. Sorry, I had to get a glass of water there for a minute. In this chart, we see the circulatory system as we have a normal responsive pediatric patient, and we see the heart rates there. Rather than try to memorize these, remember our weight length-based measuring tapes, such as the Brasler tape, to help us get our patient's range correctly. That way we can be accurate. And don't be afraid to look it up if you need to. Our pediatric patient's nervous system is immature, it's underdeveloped, and it's not as well protected as those of an adult. Um, Remember, the occipital area is much larger, which increases the momentum of the head during a fall. They have a bigger head. So uh, remember our trauma lecture with mass, 1/2 mass times velocity squared. So now they got this big head and it falls. So we can have some head injuries as a result of that. In part also because some of their areas in their head, such as the subarachnoid space, is relatively smaller than it is in an adult, and so we don't get quite the cushioning that we would with our adult patient. The pediatric brain also requires higher blood flow, higher demand of oxygen and of glucose, and because of that, they're at high risk for hypotension and hypoxia. Um, Spinal cord injuries are less common, um, in part because the many of the bones haven't hardened completely yet, so they're still cartilaginous, and they're a little bit more forgiving, if you will. With our GI system, we see again less protection from trauma because the abdominal muscles aren't as developed as they are with an adult. So that opens up potential for liver, spleen, kidney injuries. Um, so, and they're prone to bleeding. As the patients continue to grow and we move into the musculoskeletal system, we notice that the growth plates at the end of the bones allow the bone to grow as they go from softer to harder bones, becoming more flexible. But what happens then is it also makes them a little bit more prone to stress fractures. Jumping off of high objects for them, or bending in ways that, typical fracture uh, activities. The bones in the pediatric patient's head are often flexible and soft as the sutures in the skull begin to grow together and then become as if it were one um, solid bone in the cranium. Pediatric patient's skin is different in a few ways too. It's thinner, it has less subcutaneous fat, and as a result, it doesn't tolerate temperature changes as well as a mature adult. Their skin can burn really easily. They also get cold very easily. And they have a higher body surface mass ratio than an adult. So it is really important that we bundle our kids up when it's cold outside, and that we are cognizant of the sun in the summertime and making sure that we are either covering them up appropriately or using certainly the proper sunscreen. So with seeing size up for a pediatric patient, a lot of it begins before we even get there. Um, our pediatric patients can be nerve-wracking for the EMS provider. Not necessarily because they're significantly injured, but because the ratio of pediatric patients to adult patients is so much smaller. So one of the first things that we need to do is to prepare ourselves mentally um, for approaching and treating our children. You know, so we kind of have a plan. We kind of have to have a plan before we go. We don't want to just go rushing in to our scene. So even before we get on scene, or as we're walking up to the scene and we can see what's going on, we can get information about the patient without even having yet made contact, such as their age and gender, where they are, whether it was a a medical problem, or a trauma, and we have a chief complaint from dispatch, so it kind of gives us a place where we can start. And then, of course, we always want to make sure that it's safe, not just for ourselves, but important for our family or for our patients as well. Is there an environmental assessment that we need to pay attention to? What type of home are we going into? What are the conditions within that house? Is this a safe environment for our patient? If it's a scene of a traumatic injury and our patient is unresponsive or they are unable to communicate, we always want to kind of get an idea that perhaps there might be some kind of head or neck injuries. So we do a rapid assessment to make sure. This primary assessment tool, or PAT, Pediatric Assessment Triangle, is one of the most helpful tools that you as an EMS provider, an EMT or paramedic, will ever use when dealing with the patient, a pediatric patient. It's quick and it's really easy to use. And notice it's divided into 3 sections: appearance, work of breathing, and circulation to the skin. It doesn't require any equipment, and it's just 3 simple steps. What does the patient's appearance look like? Are they pale? Are they dry? Do they appear happy and normal, or do they appear in distress? What is their work of breathing? Do they appear to be working hard, or do they appear to not have any difficulty breathing at all? And their circulation. Again, we can look at the skin signs for that. From these findings, we will decide if the patient is stable and requires urgent care or requires urgent care. When we talk about sick versus not sick, when it comes to our adult patient, our patients are always, as an adult, not sick until proven otherwise. With our pediatric patients, it's the opposite of that. We want to consider our patients sick until we can prove otherwise. This is the one instance where we can go from sick to not sick. If our patients are unstable, check the ABCs, look for life threats, and transport them immediately. If they are stable, well, then we can continue with the remainder of our assessment while we're on scene. Do hands-on. Tell the patient what we're going to do. Allow them to be part of the assessment. Whenever possible, use the caregiver. As we check our airway, make sure that it's open and patent and that it will stay that way. Make sure that we don't have any foreign bodies in the airway. Ensure that it's properly positioned and clear any mucus, vomit, or blood out of there. Remember the inline neutral position, sniffing position for our patients. It may require from our pediatric patient that we pad underneath the shoulders to allow them to overcome the size of the larger head. As we assess our breathing, are we looking and listening and feeling? Do we hear air move in and out? Do we see chest rise and fall? Belly breathings in infants is considered adequate and normal. Are they breathing too slow? And if they are, we should be scared. Determine if the patient has a pulse. Depending on the size of our patient, we might want to, instead of using a radial pulse, we'll check the brachial pulse between the bicep and tricep on the patient's arm. A weak absent pulse, a peripheral pulse, indicates decreased perfusion. We know that our patient is not perfusing well, and we haven't even checked the blood pressure yet. How cool is that? Tachycardia is also possibly a sign of hypoxia. Remember, the brain has a higher demand for oxygen and sugar than it does in an adult. So it's going to create the heart going faster, trying to get what it needs up to the brain. So, what does the PAT tell us? What does our primary assessment tell us? Feel the skin for temperature, moisture, and estimate the cap refill time. In our pediatric patients, it should be less than 6 seconds. Look for any symmetrical movements of the extremities. Check for a pupil response. What is their GCS or AVPU? And there are modified scales for pediatric patients. Hands-on ABCs require that the caregiver remove some of the patient's clothing so that we can see what's going on. Do we see the chest rise and fall? Is the patient hypothermic? Should we keep the so we should keep the patient warm during transport. What is their transport decision? Can they be seen at the local emergency department, or does the patient need a specialized pediatric hospital? What are the benefits of ALS treatment in the field for a pediatric patient? What is your comfort level? How far away are we from the hospital? These are all things that affect our decision in transport. If the patient is less than 40 pounds and the state law requires or suggests that a patient should be in a car seat, are we equipped to transport the patient in a car seat? It is possible to mount the car seat to this ambulance stretcher, and remembering forward facing and rear facing as we would with a patient, with our child in a car seat. Many times the parents will be more than happy to allow us to take their child in a car seat. If we have suspected spine injury, then we want to immobilize our patient to a long board just like we would with an adult patient. If we're doing CPR, we want to make sure that we secure the patient the best we can to our stretcher. Remembering it's difficult to do CPR with a child seated in a car seat. Use your best judgment and follow local protocols. When taking history for our pediatric patient, oftentimes we have to look to the caregiver and the bystanders for the history of the patient. As we question the patient, or excuse me, as we question the parents, make sure we do so in a way that they understand that we're trying to help their child and we're not being accusatory as to what's happening or the injury or illness that's going on with their child, but that we have their best interest and we want to make them better. We need to know if the patient has any medical conditions or problems so that we can best treat their children. If they've been sick, how long have they been sick? This is really important. Have they had a fever? Have they been injured? What's their normal activity level? Is this normal for them as we see them today? Have they been eating, drinking? Have they been going to the bathroom appropriately? Always check if they're wearing a diaper to see if it's wet. Have there been noticeable changes in their bowel and bladder habits? Have they been sick, vomiting, diarrhea, complaining of tummy pain? We see any rashes or any other bumps and bruises that shouldn't be there. Get the name and phone number of the caregiver if they're not able to come to the hospital with you so that you can contact them. Obtain a sample history as best we can. Get our OPQRST as it references the pain. We ask these questions based on the child's age, and we look for appropriate answers based on how that we would expect a child of that age to answer. We do our secondary assessment again, foot to head, focusing on the suspected injured parts of the patient or the illnesses that we might have encountered. Continue our physical assessment. Do our examination of the head, nose, ears, mouth, and neck, documenting any abnormalities within any of these areas. What do we see in the chest, back, abdomen, extremities? Just like we would with an adult patient, we want to make sure that we've documented and looked at every part of our patient. Check their vital signs. What's normal for a child? If you don't know, don't be afraid to look it up. When we are checking blood pressure, for example, make sure we're using the right size blood pressure cuff for the patient that's in front of us. If we don't use the right size, that could alter the reading of the blood pressure that we get. Rule of thumb, 70 plus 2 times the child's age in years for our systolic blood pressure. But again, when in doubt, look it up. What is the pulse rate? Counting for an entire 1 minute so that we can tell whether it's regular or irregular. Assess the respirations, then the pulse, then the blood pressure when we're doing that. Remember, when a child has a significant cardiopulmonary event, it's not because they have heart disease, it's because they're not breathing right. Reassess, 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 just like we would with every other patient. Roughly 15 minutes if they're stable, and no more than every 5 minutes if they're unstable. Is their stuff working? Communicate and document. Pass that all on to the emergency department. Respiratory problems are the leading cause of cardiopulmonary arrest in the pediatric population. Failure to recognize that your pediatric patient is having difficulty breathing will lead to death. So we need to be on our A game when dealing with pediatric patient. We need to have an idea that they are breathing too slow. The mottled skin is probably from not just poor circulation, but poor oxygenation. The patient has to work harder to breathe. This can lead to respiratory failure quicker if untreated. If the patient is combative or restless or has anxiety and we're not sure why, consider hypoxia. Be prepared to ventilate your patient. If we see increased work of breathing, nasal flaring, retractions, tripoding of your child, be prepared to do CPR. As the patient progresses to a possible respiratory failure, they may have periods of apnea. Their heart muscle becomes hypoxic. They fibrillate. They go into cardiac arrest. This may be a result of trauma, nervous system failure, dehydration, or metabolic disturbance. But we need to treat them. We need to make sure that we don't miss it. As the patient progresses towards this possible respiratory failure, the child might need supplemental oxygen. Potentially, they need to be ventilated with a bag valve mask. And perhaps we might even need to do CPR. But while we're still on scene, make sure that we remain calm, put the child in a comfortable position, and we assure the parents that we're doing everything that we can. I mentioned this earlier. The pediatric patients, kids, they explore the world through their mouth. In this picture you see here, these are just a few things that kids will try to stick in their mouths and have choked on. If they fell, they hit, fell on the playground or fell off their bicycle, they could have broken or dislodged teeth in their airway. So it's not just food or things that they eat. So we need to be aware of this, and we need to do our best to um, clear that airway obstruction whenever possible. But notice some of the different infections that can also cause obstructions. If the patient is congested, they have a fever, drooling, or cold symptoms, this could lead to the following conditions such as croup or epiglottitis. Obstruction of a foreign body may involve just the upper airway, but it might be complete or partial or complete. And if it's complete, then clearly it's going to involve the entire airway. Signs associated with a partial obstruction are decreased breath sounds and the airway sounds stridor, which is kind of a inspiratory wheezy sound. Sometimes it's in the lower airway. We might hear crackles. It could be as a result of a reactive airway disorder or something that's gotten into the bronchi. If we suspect a foreign body airway obstruction, immediately begin treatment of the airway. Encourage coughing to clear the airway. If necessary, give back blows and chest thrusts. If the child is unconscious or in complete airway obstruction, then we perform abdominal thrusts. We give a head tilt chin lift. If we see an object, we remove it. If not, we begin CPR. All of this should take place. One of the medical conditions that causes airway obstruction is asthma. The bronchioles become inflamed, they swell, they get excessive mucus, makes it difficult to breathe. The airway gets gets smaller as the mucosa gets bigger. This is truly an emergency for a pediatric patient. Wheezing, tachypnea are many of the signs and symptoms that we see, shortness of breath. Treatment for the EMT, oxygen, perhaps assisted with a meter dose inhaler. Pneumonia is also another airway obstruction. Remember, pneumonia is an infection in the lung, and it can be a leading cause of death in children. The diagnosis of pneumonia must be confirmed in the hospital and is done so with X-ray. Croup happens with children between 6 months and 3 years of age and can be easily passed between children. It's a little virus in the vocal cords, and it is indicated typically by that seal bark stridorous cough. Treatment is moistened air, nebulized moistened air. You could take your child outside on a cool night. The moist air helps calm the airway and open the airway a little bit. Or you can do a steamy hot shower and take them into the bathroom with the steamy hot shower, and it has a similar effect. Humidified air, humidifiers are also very good. Epiglottitis is truly a life-threatening illness for our pediatric patient. It's a bacterial infection of the soft tissue, often manifest with a tripod position and lots and lots of drooling, kind of like a St. Bernard drooling. Whatever you do, no matter how much you think you need to, do not, I repeat, do not suction this child. You can cause laryngeal spasm, you can cause vocal cord spasm, which would occlude the airway, and your patient will die. So, high flow oxygen, blow by, keep the child calm, keep them in the position that they're in, allow them to drool, transport to the hospital. Bronchiolitis, again, is a very common illness, often confused with pneumonia in a pediatric patient, and swelling of the airways, copious amounts of secretions. Can look for signs like dehydration, shortness of breath, fever, and the treatment would be antibiotics. And of course, oxygen. Pertussis or whooping cough, again, the whoop cough that the child can get, has pretty much been eradicated, but there are reoccurrences of this. Sometimes children can pass this around in daycare and such. It is contagious, so make sure that you are protecting yourself because you can get whooping cough from your patient. So proper PPE. So when there is a need for us to use an airway adjunct, make sure that we are using the appropriate airway adjunct for our patient and for the size of our patient. OPAs and MPAs, eye gels, they might be the appropriate adjunct for this patient that we're using. And if we're placing an OPA or an eye gel in a patient, consider the fact that we are probably going to have to ventilate that patient with a bag valve mask. We have inserted something in their airway and they haven't gagged, so they're probably not breathing well. We know that the oropharyngeal airway keeps the tongue out of the airway from blocking it, can make suctioning a little bit easier, but it is designed to open the airway and keep it open. Nasopharyngeal airways, usually well tolerated. We can put them in with patients who are conscious or semi-conscious with intact gag reflex. Rarely would we want to put it, or do we need one for an infant who is under 1 year of age. And of course, the contraindications, any facial or head trauma, we don't want to use an airway, the nasopharyngeal airway. Oxygen is delivered to our pediatric patient much like it is to our adult patient. We use blow-by. Usually you can do blow-by with a non-rebreather mask holding it next to the patient, and it'll give roughly about 21% oxygen. Nasal cannulas, and then non-rebreather masks. As you can see, 24 to 95%, and then bag valve mask ventilation. So why would we use a non-rebreather versus a nasal cannula? Depends on the patient and their condition. Remember, hypoxia, respiratory failure is the #1 cause of cardiac arrest in our pediatric patient. We want to get ahead of the curve when we're taking care of our patients. Talked about this briefly. Less effective than a face mask, of course, because it's just blowing by, but it does provide concentration of oxygen to our patient. Some patients, they don't want a nasal cannula. They find it uncomfortable. The little kids keep pulling it out. Same happens often with an adult patient. They just don't like something in their nose. You can see the picture on the right-hand side. The woman with the oxygen tubing with the cup. That's a good way to do blow-by oxygen. I personally just use a non-rebreather mask, usually an adult non-rebreather mask, and hold it. It does essentially the same thing. And then we see the nasal cannula on the left picture. Bag valve mask is indicated in a patient who is either breathing too fast or too slow, and who is unresponsive and is not able to respond to stimuli. And then we would ventilate them. We are essentially going to take over their respiratory effort with the bag valve mask. And here's some illustrations of how that can be done. We've talked about this at a couple of our labs earlier this quarter, two rescuer BVM versus single rescuer BVM. Be proficient at both, but honestly, most of the time it's single rescuer bag valve. So, cardiac arrest in our pediatric patient is most often associated with respiratory failure and arrest. Cannot properly prepare you. Joe cannot properly prepare you. Nobody can properly prepare you for what it will do to you as a provider to perform cardiac or CPR on a pediatric patient. That's why we have to pay attention. That is why we have to do our best to prevent it from happening. And that is why we have to be professionals and do our job to the best of our ability. Children become hypoxic, their heart slows down, becomes bradycardic, and we have to do CPR. In your pediatric patient, if their heart rate drops below 40, I think it is, I'll have to look it up, you need to initiate CPR if your patient is unresponsive. We know that shock is a condition that develops when the circulatory system is unable to perfuse the organs. It's a common cause, some of the common causes of shock in our pediatric patient, of course, are respiratory, pulmonary arrest. Peds respond differently to fluid than to adults. They don't have the compensatory mechanisms that we do. Actually, theirs are a little bit better to a point. They don't show signs of decreased levels of shock until they've been in it and are ready to poop out. But we might see increased heart rate, increased respirations, and pale or cyanotic skin. ABCs, we do airway, breathing, circulation. The order becomes CAB if there is obvious life-threatening external hemorrhaging. We have to control the bleeding. For example, we have to initiate CPR compressions. Cardiac arrest is suspected. Don't spend too much time on the scene. Don't waste time performing field procedures. Don't worry about that I didn't get the eye gel in or the airway in if we have a patient who's in shock and we're beginning to look at ventilating them or possibly CPR. Get them in the ambulance and get going to the hospital. Meet a medic unit if you can, or just drive to the hospital, whichever is quicker. Monitor the ABCs, put them in a position of comfort, keep them warm, transport them immediately. Anaphylactic shock, one of the life-threatening shocks, as we learned already, can be common with children, so make sure that we are prepared with our dose for pediatric epinephrine. Remember that is 0.15 milligrams of epinephrine given IM. Multi-system response to, find out always what the allergen was, what the exposure was, how long ago it was, and what does our system, what does our patient look like. Any congenital breathing disorders such as hemophilia, we need to control those as best we can through our sample history, chatting with the parents, caregiver. It gives us an idea of what type of disorder the patient might have, and then we can pass that information on to the hospital. Again, control the bleeding as best we can. Altered mental status. Remember again the chart on this left side. Our valve tips. Keep those in mind. Kids put everything in their mouths. Some medicines that we take that have therapeutic effects for us can be deadly to our children. So we need to make sure that what went into their mouth. What are the signs? What are the possible reasons for their altered mental status? Seizures in a kid can be kind of scary again. Seizures, much like a seizure with an adult, can be challenging for our child. Disorganized electrical activity happening in the brain. You can look at the kid. It has a bunch of different ways, maybe a sucking motion, maybe the abnormal gaze, tonic-clonic type seizures. When a person is in their early childhood, or 6, 7, 8 years of age, that's typically when disorders such as epilepsy can be diagnosed. Earlier than that, seizures can be caused by fever, as it says here, some of the common causes. And the fever, febrile seizures, we call them. It's not how high the temperature is; it's how rapidly it went from one temperature to the next, to the highest temperature of that which causes the seizure. So notice some of the different reasons there: child abuse, electrolyte imbalance, glucose levels are messed up, hypoxia, poisoning, seizure disorders, trauma, etc. And sometimes they just don't know why they have a seizure. So reoccurring prolonged seizures should be considered life-threatening, and we should call ALS for that. We had a little boy in our area that we responded on. He's just over a year old now. He has had, for me, a seizure that lasted about 45 minutes from the time that mom called to the time that we arrived at Meredith Hospital, and seizing all the way. So this can be a truly life-threatening. Anything over any prolonged seizure, status epilepticus. Meningitis, infection in the meninges, in the spinal cord, and around the brain. This can be life-threatening for our pediatric patients. So it's important that we are able to recognize some of the things. For example, who are at greater risk for meningitis? Newborns, compromised immune systems, brain spinal cord injuries, children who have head trauma, children with shunts, pins, or other foreign bodies. And the signs do vary, but if they get this bacteria in them, it has rapid onset and can lead to death. So they could get a small pinpoint cherry red spots, or maybe larger purple-black rash on them that are sometimes indicative of meningitis. Complaining of headache, stiff neck. Here's a picture of that rash that a meningitis patient can get. For us as rescuers and EMS providers, we want to make sure that we are using standard precautions. This is where we want to make sure that we're wearing not just gloves and glasses, but also a face mask so that we don't get this. Trust me, you don't want meningitis. Never take the complaint of abdominal pain lightly, as it could be a sign of so many different things. Remember, their abdominal muscles aren't completely fully developed yet. So Um, they don't have the protection that you and I have because our abdominal muscles are all put together. Um, and stuff isn't quite as developed. So they might have difficulty digesting food. They could have a hernia. Um, they could, you know, be dehydrated. Many different things could happen. Appendicitis is one of the most common abdominal problems with our pediatric population. So make sure we're properly evaluating the patient. If they're complaining of any pain in the lower abdomen, right side, around their belly button, or pain that's referring into their shoulders or anything like that, then we need to consider uh, appendicitis. This is where some of our questions again that we ask our patients, are they going to the bathroom? Is everything working okay? They're super, super important. Poisoning is also common with our young patients. Again, because they explore the world with their mouth. So perhaps they ate grandma's metformin, and which would cause quite a adverse reaction to our child patient. Um, as I said earlier, some of the substances and the medicines that we take for therapy can be fatal for our children. So things we need to know. What substance do we believe is involved? How much did they take? When did it happen? Any changes in their level of consciousness or behavior? Have they choked or coughed or have they thrown up or anything like that? And then contact poison control. Um, and again, the number for poison control is 1-800-222-1222. And that is poison control's number all over the United States. Dehydration can be serious. Remember, their tanks are smaller and it takes less for them to be dehydrated. So it can be life-threatening because they might not have the ability to overcome the heat-related or untreated shock, whatever the cause might be. So fever, we talked about this a little bit with causing febrile seizures. So any temperature over 100.4 or higher is considered a fever, but a normal fever is rarely life-threatening. It's when it gets really high, 103, 104, that we're starting to really worry about it being life-threatening. So typically the management for a fever would be to try to, use cooling techniques. Uh, Most parents, have been advised by their pediatrician to use NSAIDs, Tylenol, or so pediatric doses of Tylenol or ibuprofen to help control the fever. And then if it persists, find out why they're having the fever, what problem is going on. So if our patient presents with a fever and has respiratory distress, or they have a stiff neck, or a rash, or hot skin, then what are other things that we're thinking about? Maybe it's meningitis, maybe it's, um, they have pneumonia, or whatever it might be. And meningitis, bulging fontanelles, remember swelling in the brain, that kind of stuff, hydrocephalus, many different things it could be. Febrile seizures, again, we talked about this a little bit, between 6 months and 6 years, and characterized by a typical tonic-clonic activity, usually less than 15 minutes, a little bit of a post-ictal state, and it will usually be the first day of a patient feeling icky, cardiac illness with the fever. Second most common cause of death, unintentional death amongst our pediatric population, our pediatric population is drowning. So children under 5 are most at risk. And when it says alcohol is a factor, it's not alcohol, the children, except maybe adolescents, because adolescents and young adults, they're experimenting. Remember, they're going through that part of life where they're pushing the envelope, um, and so they're experimenting with different things. And maybe it's drugs, maybe it's alcohol, maybe it's sex. So alcohol, or the parents are having too much alcohol, kids are playing in the pool or at the lake, and parents aren't paying attention, and the drowning happens. And those are some of the scenarios that can happen. So a few minutes without oxygen affects the heart and lungs. We know that. Hypothermia from submersion in icy water can affect our how well we can resuscitate, or a possibility of having successful resuscitation. Keeping in mind also that resuscitation in freshwater drowning is harder than resuscitation in saltwater drowning, because the freshwater washes away the pulmonary surfactant. Um, some of the signs and symptoms, of course: how long have they been in the water? What's the length of their immersion? Are they breathing or not breathing? Coughing, gasping, that kind of stuff. And then management would be clear the airway and perform CPR if they're not breathing. Trauma amongst children is the #1 killer of children in the United States. The muscles and bones continue to grow well into adolescence. So fractures of femur are rare. So if you have a child with a femur fracture, they endured some pretty significant trauma. Older children, a little bit different. They're more susceptible to long bone fractures. So some of the physical and psychological differences: obviously, children are smaller than adults, so the locations of the injuries may be different. Um, the force of the injury that affects on the structure is different, because to a certain age, the bones are softer, um, they're more pliable, it takes more force for it to be broken. Um, Conversely, their head is pretty big and proportionally larger than the adults, and so it exerts greater stress on the neck and other structures during deceleration injuries. It's important that we consider this when motor vehicle collisions are involved, particularly car, pedestrian, motor vehicle collisions with children. Um, they will dart out into the roadway, often without looking. Maybe they're running out to see something or whatever. They don't pay attention. They run out. Some of the typical injuries that they sustain are to the head, whereas an adult will turn and look at the car, and will be tossed over the car. A child is often not paying attention and hit by the car and then run over. We see increased sports injuries with children, especially adolescents, and school-age children as they're in school. Organized sports, head, neck trauma, football, wrestling, etc. Remember, follow local protocol always, but immobilize the C-spine if necessary. And again, head injuries are common because of their larger head ratio than the rest of their body. Scalp and facial injuries can be cause a great deal of blood loss if not controlled, so be aware of that. When necessary, consider the possibility of head and spinal injuries after a traumatic event, and immobilize according to local protocol. Blunt force injury, blunt trauma can result from a variety of reasons with our pediatric patients. The chest wall is relatively flexible. That doesn't mean that blunt force trauma to the chest just because there's no broken bone isn't causing damage to the structures underneath the chest. So be aware of that. Monitor all patients for signs of shock, treat appropriately, and cover them with a blanket, and take them to the local hospital or trauma center. This illustration shows us some of the possible injuries that might result from our patient. Notice a fractured leg in a grown-up, the same type of um, mechanism might cause this injury in an adult, but may cause severe abdominal trauma in a child. Burns can be life-threatening. Again, remember the mass to surface ratio of a child is smaller than it is, so they don't tolerate burns well. Their skin is thinner. It gets burned up easier. It doesn't get burned up easier, but because it's thinner, it gets damaged easier, and then the structures underneath the skin are damaged easier as well because of the skin being thinner. So exposure to hot surfaces, stove tops, items on the stove, pulling the pan off, that kind of stuff, caustic substances. Those are all common causes of burns. And then infection is a common side effect of a patient who has burns. So when we're looking at patients, particularly our pediatric patients with burns, we need to consider the possibility of child abuse as the cause of the burn. So if somebody pulls a pan off, a kid pulls a pan off the stove, there will be burn pattern from like the top down, chest, legs, foot, etc. But if you see burn patterns where it is entirely, there's like a clear demarcation on the arm or hand, then that's a possible child abuse. And when in doubt, I'm going to repeat this, when in doubt, report it. EMTs, first responders, are mandatory reporters. Anytime that we suspect child abuse, it is our duty to report that. So when in doubt, report it. You cannot be held personally liable for that if you, in good conscience and good faith, report it what you believe to be a possible child abuse. Some of the injuries to the extremities, again, might affect the growth centers of the bone. If the epiphyseal plate or growth plate is injured or damaged, that might not continue to grow. So we might have a short leg or a short arm or whatever it might be. Different types of fractures can occur also, as it mentions there, incomplete or green stick fractures. So a green stick, if you think about, you know, a green branch, when you try to break it, it breaks and then there's little areas, but it doesn't break all the way through. So with pain management, there's the Wong-Baker faces pain scale, which are the smiley and frowny faces that you've probably seen before when you've taken your kids to the doctor, or if you remember when you were younger, maybe they had them then. So consider ALS intervention if needed, but most of the time with pediatric patients, recognizing the patient is in pain, doing your best to splint or isolate, elevate that. We'll do a lot. You know, I'm going to show up with my medic unit and drugs, and I might be able to take the patient's pain away, but I'm going to poke them with the needles to do it, and that could potentially make the situation worse. So just keeping that in mind when we're taking care of our patients, we're looking at pain management for our patient. We're going to talk about triage a little bit later in the class, but we talk about it a little bit here. It's intended, so Jumpstart is a pediatric triage system. for 8 kids that are roughly under 8. And again, it's green, yellow, red, or black. Um, and it's a triage system to help us kind of make the right decisions for pediatric patients. So green, minor, or not in need of immediate treatment. They're able to walk, obviously, except for infants. Yellow, delayed treatment. In other words, we can move them with the green patients. Maybe they need some care when they get over there, but they can get like an inhaler, or they have some minor cuts and bruises that they need to get um, checked out, but their treatment isn't like emergent right away. Red is immediate, unresponsive, so we position our patient if they have respiratory failure or inappropriate painful response, and then we take care of them as best we can. And then our deceased or expected deceased patients are apneic without a pulse. So if we have somebody who's not breathing and we have personnel, we can, so back to the red, we can um, ventilate them, and hopefully they will have spontaneous respirations after a little bit if we have personnel. But going back to the black patient, we expect that they're not going to, they don't have a pulse, we don't have the personnel. Disaster management, talk about that a little bit again as it relates to Jumpstart, and we'll have a whole class on that a little bit. Child abuse and neglect. This is again one of those uh, difficult to hear class parts of a class that are challenging, that will challenge all of us as we are taking care of our patients. By definition, any improper or excessive action that injures or otherwise harms a pediatric patient is abuse. This includes, but is not limited to, physical abuse, sexual abuse, neglect, emotional abuse. 500,000 pediatric patients are victims of abuse annually. 500,000 kids a year. Some of these are life-threatening, some of them are not. If it goes unreported, the cycle typically continues. So what are some of the signs that we can look for? You are called to the homes because people of reported injury to a child. Okay, when we get there, what do we see? Now, don't get tunnel vision that this is just in the bad neighborhoods or the poor people that have it. Abuse, child abuse, happens to everybody, regardless of their socioeconomic status. It can happen to in any setting that we respond to. So what do the surroundings look like? What do they tell us? What is the child saying to us without saying anything? How is their interaction with the parents? Do they seem afraid? Ask yourself, is this typical for a child of this age? Does the MOI that was reported line up with the injury that we see on the patient? Is the caregiver behaving like they should? Has there been evidence of drug abuse or alcohol? Hmm. Was there delay in calling? What's the relationship between the parent and the child, or the caregiver, if they're different? Are there multiple injuries in different stages of healing. Now let's pause here for a second. And then the next bullet point there, any unusual marks or bruises that have been caused by cigarette uh, branding, injuries, grids, or anything like that. So back up to multiple injuries in different stages of healing. Now, if you have an active toddler who's exploring the world by running around and bumping and bruising themselves, we're not saying that that patient in particular is a victim of child abuse. But what I am going to encourage you to look at with this is, where are those multiple injuries? Are they on the knees? Are they on the elbows? The places where we fall and go boom when we're a little kid and we're exploring the world. The places that we would see that, maybe a bump on the forehead, is that, remember, they have a big head. It's the injuries in different stages of healing that are on places that are not consistent with a little toddler running around exploring the world and falling down and learn how to walk and stuff. It's the injuries on the back of the head, injuries on the bottom, you know, those kind of things. Injuries that are inconsistent with the mechanism of injury that has been described. And then, are there several injuries? There's a cut here and a bruise over there, twisting, injuries, bruising that looks like a handprint. Does the patient have an unexplained decreased level of consciousness? I responded on a 3-year-old girl who climbed on top of a dresser. The dresser and the TV fell over on top of her and smashed her in the head. She was unresponsive when we arrived on scene. We wound up intubating her and transporting her. She was flown to Marybridge Hospital. The concerning part of that wasn't that the kid climbed up the dresser and knocked over the TV. It was the fact that the parents seemed to not care that we were doing CPR on their daughter. They seemed to not care. They were more interested in smoking their cigarettes and wondering when we were going to leave. Law enforcement was notified. Law enforcement was on the scene, and they were arrested for child endangerment. So it does happen. Is the child clean for their appropriate for their height and weight and age? Excuse me. I don't know why I put weight. It said weight. It says it right there. Are they of appropriate weight? Is there rectal or vaginal bleeding? All of these questions that we need to ask ourselves. There's a mnemonic we can look at, child abuse. Leave that there for a minute so you can look at it. Some good information. History consistent with injuries, inappropriate, parental concerns, lack of supervision, delay in seeking care. What's the affect? Bruises in varying ages, of varying ages, suspicious circumstances, and then anything in the environment on scene that might give us an idea that something isn't right here. So what does the color of the bruise look like? We know that as a bruise initially happens, especially if it's trauma, it's going to be a dark, deep purple color. And then as it gets lighter and lighter, kind of goes through a little technicolor, kind of yellow, and then fades away. What are the bruises look like? And that gives us an idea of how old they are, and if we have bruises in varying ages. Burns. If we see burns to the genitalia, that could be inflicted by someone else by dipping the child into scalding water and burning. If there are burns on the hands and feet that look like a glove, again, submersion burns, possibly by dipping into scalding water. Falls off of beds are not usually associated with fractures, so that's always a good thing. Is what the caregiver telling us consistent with the injury that we see? Um, Again, shaken baby syndrome. Um, it tears the blood vessels in the brain, results in bleeding around the brain, swelling, and then ultimately can result in death. So our unresponsive, our lethargic baby, um, and we're not really sure why. Maybe our spidey sense or red flag should be sent up, just to kind of get an idea. Better to report it and it not be than to wonder if it was and not report it. And then neglect, failure to provide for the necessities, life's necessities, food, clothing, shelter, good personal hygiene, medicine, personal safety. Um, these are all signs of abuse. So some of the things we can look at with our patient, they might appear to be fearful. Maybe they're angry all the time. Maybe they withdraw when they see us. We represent a threat, or they don't want to tell us. Or the parents reveal a history of accidents. Um, it might be appropriate for us to examine the child and ask them what happened um, aside, out, um, excuse me, without the parents there. I mentioned this earlier. EMTs in all states must report suspected abuse. Most states have a special form to do this. Um, Law enforcement and child protective services will determine whether there is abuse, but it's our job, if we suspect the abuse, to report it. So if we're on scene, perhaps we call for law enforcement to meet us at the hospital, or maybe we're going to be there a while, have them respond if their ETA isn't really long to come. Don't withhold providing adequate patient care to wait. Um, Document it to the best of your ability. We have some unusual incident forms in Kitsap County that we fill out anytime there's anything to do that's unusual with a child. Um, Again, follow your local protocol. Sexual abuse, as we mentioned, is another form of child abuse. And it can happen at any age and to any gender. So do not examine genitalia unless there is evidence of bleeding or injury. Take that person to the hospital, contact the sexual assault nursing examiner, or have one at the hospital when we arrive. Do not allow the child to wash, urinate, go to the bathroom in any way until a physician has completed their examination. If possible, ensure that there's an EMT or police officer of the same gender. Maintain a professional composure. I'm going to repeat that one again. Maintain a professional composure. This will be one of the most challenging types of calls that you will ever go on, is sexual assault of a child. And it may require everything that you have within you to not react towards the alleged abuser, because honestly, we don't know. And we don't want to have a suspicion thinking it is one person and it wound up being somebody different. And then we say things or do things on scene that could be potentially hazardous. Um, so we don't want to do that. So be professional. Our job is to take care of the patient, period. not to pass judgment, not to defend the patient, not to retaliate or anything like that. Our job is to maintain a professional attitude and composure and professionally take care of the injured person in front of us. Get as much information as you can as possible. Remember, this is a crime, so law enforcement needs to be involved. Sudden infant death syndrome, is a diagnosis of a dead baby. There is no near SIDS. There is only SIDS. 3,500 on average die of SIDS each year. They're still not sure why it happens. Is it because they're sleeping on their belly? Is it because they're sleeping on their back? Is it because they have, bumpers and blankets and toys in their bed? Is it because there's co-sleeping with the parents? They really don't know. It's impossible to predict. It is devastating for the parents. So, what do we do? First of all, what are some of the risk factors? A younger mother, maybe they smoked during pregnancy, maybe there's a low birth weight. It can occur any time of the day. It doesn't have to be when they're sleeping at night in bed. So we have to assess the scene, assess and do a management of the patient, take care of them appropriately, provide CPR or not. The scene will dictate what we do, and then communicate, give support, contact your local responders who come with you. Maybe it's a chaplain that comes out and helps talk with the parents. Coroner's office, law enforcement will be involved. Any unexpected death, especially an unexpected death of a child, needs to be investigated. This is not anything the parents did. We need to comfort the parents. We need to provide for them as best we can. Some parents will be insistent that we do CPR and work their child and transport them to the hospital and do everything that we can. And other parents will recognize that their child has passed, that they have died, and they will ask for the appropriate assistance that I mentioned, coroner's office, chaplain, service, law enforcement, etc. We're doing our patient assessment, and we suspect child abuse, or excuse me, SIDS. The patient will be pale or blue, not breathing unresponsive. We don't really know what the common causes are, as we mentioned in the last slide. But depending on how much time they might show lividity, they might not show lividity, we might begin CPR, we might not begin CPR, I mentioned that already. So, what does the scene tell us? Look for signs of illness, general conditions of the house, poor hygiene. These will all be documented in our unusual incident report. Again, many systems have, anytime there's a death of a child, there's an unusual incident report that we'll have to figure out. Or we could just also document this in our patient care report. Communicate, provide support to the family. Strong emotional responses amongst healthcare providers. This will hurt. This will hurt really bad. Maintain our professional demeanor to the best of our ability on scene, but it's okay to be human. Okay. And allow the family to express grief. Allow them to be angry. Allow them to be go through the stages of grief if they need to. Those are normal. Those are normal. Anytime there's a death of a child, it is a challenging call for sure. It's challenging for the family. It's challenging for the EMS provider on scene. Um, if the family wants to initiate CPR, resuscitative efforts, then, and it doesn't conflict with local protocols, then, you know, perhaps you can, again, follow local protocols. Introduce yourself to the parents, the caregivers, you know, get information about the child. Do not speculate the cause. We're not the coroner's office. We're not doing an autopsy on the child. We do not know why that child died. Use their name. Don't speak of them as, you know, the baby or whatever. Use the child's name whenever possible. When we're talking to the family and we're informing them that their child has died, use those words. I'm so sorry, you know, your son or daughter has died, or we've done everything that we can, but they have died. Instead of words like passed away or gone. Acknowledge their feelings, offer to call family members. If we have to give any instructions, keep them short, simple. Wrap the child in a blanket, stay with the family while they hold the child, stay with them according to your local agency's protocol until law enforcement has arrived or the coroner's office. What happens? And remember, everybody expresses grief in different ways. And many of us as caregivers, and many of them as caregivers, will feel like they are responsible. And those of us who are in EMS system, you know, we might feel like it's our fault that we didn't do something for that child, that we couldn't do anything. So we are also going to go through some grief as a result of this. Take time before going back to the job. Make sure that's okay for us. If you have children of a similar age, call out of service for a little bit. If your agency will allow you to do that, call them up, talk to them, go visit, whatever. Look for the signs of PTSD, not just in yourself, but in other people. Remember the behavior lecture I talked about. Take care of each other. We have to be there for one another. We have to consider, we have to think about everyone who needs help on that scene. And sometimes we're going to go to a call where it's, you know, the ALTE, apparent life-threatening event, such as a child not breathing or cyanotic, um, you know, whatever it might be. We've referred to them recently as sentinel events. The almost one in a lifetime, this may never happen type of call. We don't really know what happened, uh, but something is wrong, and this child looks like they're going to die. So take care of ourselves, take care of the patient, do our best. ABC is always. So. After the apparent life threat, um, the patient survives. It may be like nothing ever happened. Um, we got to do a complete and thorough assessment, provide rapid transport to the emergency department, pay attention to the ABCs, get the best history that we can, let the doctors determine the cause when we arrive on scene or when we arrive at the hospital. All right. So that's a quick overview of our pediatric patient. If you have any questions, please do not hesitate to reach out and ask. Again, thank you. Have a good night.